Hand the call over to your speaker today, Mr. Mark Schomer. Please go ahead.
Thank you for joining us for the COVID-19 media briefing for March 5th. We'll start today with opening comments from Health Commissioner Jan Malcolm, Dr. Tyler Winkleman with Hennepin Healthcare, Infectious Disease Director Chris Ersman, and State Epidemiologist Dr. Ruth Linfield. We'll then open it up for questions from reporters on the line. With that, I'll now turn it over to Commissioner Malcolm.
Thanks, Mike. Good afternoon, everyone. We reported an additional 813 positive cases today on a testing volume of 37,165 tests reported into us yesterday. We've been fairly stable for the last week or so in terms of the rate of change in cases week over week, and the same has been true for testing. The 7-day average test positivity rate remains at 3.6%. So that has been a stable metric for a couple of weeks now, which is great to see. Unfortunately, though, we reported another 13 COVID-19 deaths this morning that were reported into us yesterday, bringing us to a new total of 6,534 of our fellow Minnesotans who've lost their lives to COVID-19 since the start of this pandemic. Currently, we have 224 people in the hospital in Minnesota being treated for COVID-19. Of those, 57 of them are in intensive care. Moving to the vaccine situation, we're getting very close to 1.5 million total vaccine doses that have been administered to Minnesotans as of Wednesday, as shown on the dashboard. That's when the data have been reported into the immunization information system. And that is the total of both first and second doses. But the number of people with at least one vaccine dose is now over 975,000, with 516,000 of those having had a complete series of COVID vaccination. I'd like to spend a few minutes talking about the news release from earlier this morning, announcing that we have just added vaccination data by race and ethnicity to our vaccine data dashboard on the web. This data will inform the state's outreach efforts and specific strategies to ensure the equitable distribution of vaccine to Minnesotans of all races and ethnicities, including underserved populations and communities disproportionately impacted by COVID-19 as a result of systemic inequities. The publication of this data was made possible through the groundbreaking partnership between the state of Minnesota and the Minnesota Electronic Health Records Consortium. This partnership represents a really unique and innovative collaboration between public health and healthcare systems. Our Minnesota Department of Health has been collaborating with the Electronic Health Records Consortium throughout the pandemic, first to identify and address disparities in COVID-19 testing, and then expanding into analysis of vaccination disparities once vaccines began arriving in the state just 2 months ago. Through weeks of careful planning, these groups have established a process to generate high-quality, reliable data that will better inform our vaccination strategies for all of our partners who are administering vaccines across the state. The data that is now populating the dashboard are generated when participating health systems produce a summary report for their patients who have received a vaccine as reported to the Minnesota Immunization Information Connection, or MIC. This summary data also includes vaccines delivered by community vaccine sites, pharmacies, retailers, and private clinics in Minnesota. Data reported by the consortium does not represent information for all vaccinations and does have some limitations, including unmatched patient profiles and patients with no existing data or no race or ethnicity information. Also, vaccine recipients must have received care from one of the participating health systems within the last 10 years in order to have their information included in the summary data. However, as more systems contribute data, and as we keep working together, we can continue to improve the data and use it to address equity gaps. In addition to the Electronic Health Record Partnership, Minnesota is using the COVID-19 Vaccine Connector to gather detailed demographic data to further inform our ongoing equitable vaccine strategies. By voluntarily providing this information, people who are using the connector are helping us to gather detailed demographic information, including race, ethnicity, medical assistance status, and other things to be able to access more disaggregated data and keep our goals on target, as well as using this to proactively communicate with different groups of people as they become eligible for vaccine and as vaccine is available in their communities. Each of these data sources alone hold a lot of information about COVID-19 vaccination status and patient demographics, but they work especially well when we put them together. The power of this collaboration is that we're now able to have a clear view of who is getting vaccinated in Minnesota and to work together to close equity gaps. Equitable vaccine distribution is a core principle of the Wall Flanagan administration's COVID-19 vaccination strategy. To date, our administration has worked with providers in focus communities across the state to ensure that BIPOC Minnesotans have access to the limited supply of vaccine doses shipped by the federal government. MDH is also partnering with 30 experienced and trusted community organizations and diverse media vendors in Minnesota to provide culturally relevant, linguistically appropriate, accurate, timely messages related to COVID-19 through trusted leaders in communities, including vaccines. As vaccine eligibility expands and the Biden administration promises larger shipments to states in the coming weeks, the Walt Flanagan administration is broadening our strategies to provide equitable distribution and access in the following ways. We will be expanding vaccine distribution to more community clinics and directing more doses to more community pharmacies located in communities in particular need of additional vaccination attention. We will be expanding our vaccine delivery to community-based vaccination sites in partnership with healthcare providers and local community organizations. We will be working to more proactively connect members of our focus communities to vaccines in their area. And we'll begin deploying mobile vaccination units to particularly hard-to-reach populations. Additionally, earlier this week, the Health Department issued updated allocation and prioritization guidance to providers of vaccine all across the state to inform best practices for vaccinators. This guidance provides recommendations for sub-prioritization factors to address systemic inequities and the disproportionate impact of COVID-19. Specifically, MDH recommends that vaccinators prioritize people 65 years of age and older who are dual eligible for Medicare and Medicaid, and younger people who participate in Minnesota healthcare programs as they become eligible in later phases. And some communities have suffered disproportionately from COVID-19, and we know that from the data on numbers of cases, but particularly severe cases resulting in hospitalization and even death. These communities that have suffered disproportionately include communities of color, certainly older adults, people with disabilities, and people with comorbidities. And we've made explicit in guidance that the presence of multiple risk factors should be considered by providers as they sub-prioritize within groups. We care deeply about ensuring that each and every Minnesotan in every community from every walk of life has fair and equitable access to the vaccine. We're going to use this groundbreaking data partnership and the insight into the data it provides to help us drive improved and increasingly targeted strategies to better serve communities disproportionately impacted by COVID-19 over the last year, including Black, Latinx, Asian Pacific Islander, and Native communities. We will also continue to work with community, healthcare, and public health partners to provide access in a way that specifically addresses those systemic inequities and works to close the current gaps we see in the data. With that, I would like to turn this over to Dr. Tyler Winkleman to talk a little bit more about this innovative data partnership. Dr. Winkleman.
Thank you, Commissioner Malcolm. It's a pleasure to be here with you to discuss the work of the Minnesota Electronic Health Record Consortium and our partnership with the Minnesota Department of Health. The mission of the Minnesota EHR Consortium is to improve health by informing policy and practice through data-driven collaboration among members of Minnesota's healthcare community. In March of 2020, as the country was preparing for the first surge of COVID-19 in the United States, it became clear that this public health crisis was an all hands on deck situation. The health systems and MDH built on previous conversations about collaboration, to develop a multi-system state partnership to provide data that could inform a response by government and health systems to the COVID-19 pandemic. Over the past year, we've worked closely with health system operational leads and MDH to build resources that provide actionable data, such as the race and ethnicity vaccine data released today. This is a true partnership and collaboration that links the work of public health and health systems in Minnesota and provides critical information to manage the largest public health crisis in our lifetimes. It also builds the infrastructure needed to identify emerging public health threats and be prepared for other important public health issues. The Minnesota EHR Consortium offers an important resource to identify inequities across the state. We have worked collaboratively to standardize our processes across each of the participating health systems to produce high quality, comparable data throughout the state. And we are continually identifying ways to improve the quality of our data to better and more quickly inform policies and practice in Minnesota. Health systems have already implemented a number of strategies to improve equity in the administration of COVID-19 vaccines. Our operational partners are using the consortium data to identify community engagement and vaccination strategies to improve vaccine equity and ensure all communities have access to vaccines and the knowledge they need to make an informed decision. Our data show that we have work to do to improve vaccine equity, and they'll provide us with a critical tool to measure our progress in the coming weeks. So with that, I will hand it over to Chris Ersman.
Thank you. I'd like to speak a little bit about the vaccine connector and also address some concerns that we've been hearing from primary caregivers about how they can sign up for vaccines. So I want to acknowledge that under our current eligibility guidelines that were posted on Tuesday, that paid and unpaid primary caregivers are eligible to receive the COVID-19 vaccine, even if they live in the same household as the person that they care for. Caregivers are classified as healthcare workers and are included in the highest priority group to protect Minnesotans with disabilities and others who are vulnerable to the pandemic. Eligible unpaid caregivers include primary caregivers who work in similar capacities to personal care assistants, direct support professionals, and nurses for people with complex medical needs. MDH is encouraging caregivers to sign up as soon as possible for vaccine appointments using the Vaccine Connector tool. There are appointments available right now. Unfortunately, right now, and we are working to address this and make some changes to the connector, but unfortunately, currently, we do not have a specific option for primary caregivers at this time, but here's how you should sign up. Under the demographic details, indicate that you're a first responder or a healthcare worker who provides direct patient care. Select no for the question of if you are employed, can you work from home? Because you can't. When asked about what industry you work in, select the other box and write in primary caregiver. You can also reach out to your local public health department to see if they are scheduling appointments. And then just so that you have some documentation, here's some examples of how you can show that you're a caregiver of a person with complex medical needs. If you're providing care through the Community-Directed Community Support, or CDCF, you might provide paperwork showing inclusion in that plan. You could also provide a letter, either from a physician or other involved party, that you're doing this work, and there is a sample letter on our website. And we do apologize for any confusion in making sure that primary caregivers can get vaccination. We're working to make that process clearer. I also want to acknowledge that if you're a senior, 65 plus, we've talked about primary caregivers or frontline healthcare workers. If you're a child care worker or an E12 educator, there are COVID vaccine appointments available this weekend in Bloomington at the Mall of America site and in Egan at the Vikings training facility. So you would want to sign up on the Minnesota COVID-19 Vaccine Connector. And just to make sure that you have that, it's https://vaccine connector, one word, .mn.gov. And then you would be looking for a scheduling email from Primary Bio, and that will have a link in it. You can also call the Vaccine Connector hotline, and that's 1-833-431-2053. So we just want to make sure that people who are eligible to be vaccinated right now, are using the connector to make sure that they have made their need for vaccination known. And with that, I'll turn it over to Dr. Ruth Linfield.
Thank you very much, Director Erzman. I'm going to speak on variants and the importance of mitigation measures and also talk a little bit about travel. Like other viruses, SARS-CoV-2, the virus that causes COVID-19, can develop genetic mutations when it makes copies of itself. Most of these changes are minor and do not influence the way that the virus behaves. However, some variants have emerged that are associated with a change in the virus's ability to transmit between persons and may change the severity of illness and the response to prior immunity or to vaccine-induced immunity. These are called variants of concern. And we are tracking and reporting to CDC 3 variants of concern. B117, which is the variant that was first identified in the UK. P1, which was identified first in travelers from Brazil. And B1351, which was identified first in South Africa. In the United States, as of yesterday, CDC reported 2,672 cases of B117 from 48 states. 13 cases of P1 from the 7 states and 68 cases of B1351 from 17 states. Globally, there have been cases of B117 reported from 94 countries, P1 from 25 countries, and B1351 from 48 countries. We have identified cases of B117 and P1 in Minnesota, but as of today, no cases of B1351. We are conducting surveillance for variants through 2 approaches, a targeted approach and a random sampling approach to sequence COVID-19 PCR positive specimens. This latter approach provides a background of what is circulating in Minnesota. We are currently sequencing approximately 150 to 200 specimens a week and plan to increase this amount over the ensuing weeks. To date, we have found 2 people infected with the P1 variant and who had traveled to Brazil. We have identified 165 B117 cases to date. However, we know that this is an underrepresentation of the total number of variant cases in Minnesota, as we are only able to sequence a small proportion of the total confirmed COVID-19 cases. We have identified cases in all 7 metro area counties, as well as 8 other counties. These are Blue Earth, Chisago, Isanti, Kennebec, Meeker, Mille Lacs, Pine, and Wright. This emphasizes to all of us the importance of prevention and control measures in the community. It is critical that we not let down our guard. We have identified several clusters of B117 cases. We have seen spread to household members and others in the community. We are currently investigating clusters of students in middle and high school and student athletes involved in various sports. I'd like to remind you that B117 is thought to be more contagious than routine strains. That means, again, it is so important that people maintain good prevention measures. Even with the positive momentum we see on vaccines, so many Minnesotans are still vulnerable. And we could see another spike in cases around the state if we are not careful for the next few months. We are asking that Minnesotans wear masks appropriately, keep social distance, be aware of symptoms, and get tested if symptoms develop, or if you are exposed to a case. Please be compliant with isolation and quarantine if infected or exposed. To that point, I want to share a quick message on travel. We know spring break is approaching for many schools, and this is often a time for people to head out on leisure travel. We remain concerned about travel during the pandemic, and we urge Minnesotans to consider delaying non-essential travel. If travel must be done, please follow CDC guidance. Please lay low before you go. Test 2 to 3 days prior to travel. Be really careful during travel, and quarantine and test after returning from travel. Please monitor carefully for symptoms. If you decide to travel, follow these recommendations to protect yourself and others from COVID-19. Take safety precautions when gathering. Limit interactions to small groups, ideally less than 5, and gather outdoors whenever possible. Stay 6 feet away from anyone you do not live with and wear a mask. Wash your hands or use hand sanitizer often. Avoid high-risk situations like crowded bars, events, parties, or other situations that would put you at risk of contracting COVID-19. Watch for symptoms. Get tested if you develop symptoms. Stay home and away from others if you become sick. Even though you may not be at high risk for severe disease, remember COVID-19 is a contagious disease, and it can spread easily, and it can spread from people who do not have symptoms. Minnesota strongly recommends that those who travel do the following when they return. Get tested 3 to 5 days after you return. Again, lay low and self-quarantine, ideally for 14 days, although other shorter quarantine options may apply. Stay away from individuals who are at high risk of complications from COVID-19 for at least 14 days after you return, no matter what quarantine length you are able to do. We all need to work together to ensure that we are making progress toward the end of the pandemic, especially now that we are seeing highly infectious variants circulating in our communities and circulating in the United States and abroad. Thank you. I will now turn the conference back to Mike Schomer.
Thank you, Dr. Linfield. Operator, we're ready to take questions.
All right, so as a reminder, To ask a question, you will need to press star 1 on your telephone. To withdraw your question, press the pound key. Again, that is star 1 on your telephone. Please stand by while we compile the Q&A roster. We do have a question from Theo Keith from Fox 9. You are now live.
Hi there. Wondering if you can give us the numbers for next week's allocation. Obviously, we know that there will be no Johnson & Johnson, but what are the numbers for Pfizer and Moderna?
Chris, do you happen to have that handy? Chris, if you are on mute, if you're hearing the question. Well, I think not hearing Chris. I hope we didn't lose her on the line, but I think we can. If you can just call the office here, Theo, we can get to that.
Okay, thank you.
Yep.
Next one on the queue is Glenn Howell from Star Tribune. You are now live.
Thank you. Commissioner, a couple of weeks ago at a community event, you said that the state would hold healthcare systems and providers accountable for meeting equity vaccination goals. Are you still considering that? And if so, when will that take effect?
Yes, Glenn. I think certainly the data that we're announcing today is in the aggregate, but very, very valuable data. In addition, all of the systems, the large systems who are working together as part of a specific coalition, all have equity plans and are developing kind of their own equity dashboard that they will be sharing with us. We're very grateful for the plans. They're responsive to our requests, but I think measuring how we are doing collectively and how each vaccinator stream is doing on equity measures as well as timeliness measures will be increasingly important as we start to broaden out the eligibility categories.
Thank you. And yesterday, MDH, in its weekly provider guidance, told providers that they will now be required to submit racial and ethnic data to MIC. Is this the result of that reinterpretation of the law by your lawyers, and how will this data be used in connection with the electronic health record collaborative data?
Yes, that's right, Glenn. We have some new legal interpretation that under other provisions of law, we are able to require that data to be submitted. It had previously been voluntary. So yes, we do expect all providers to now be reporting to be collecting race and ethnicity data. It does remain voluntary for people to agree or not agree to report that data, of course, but providers now will be required to report that in MIC, and that will just be additional coverage, if you will, of the number of records in MIC that have that data that can be cross-referenced with the Electronic Health Records Consortium. So it'll just help to fill in that 15% or so of data that is missing at present.
Thank you.
Again, if you would like to ask a question, please press star 1. Next one on the queue is Dan Quaker from Minnesota Public Radio. You are now live.
Hi, thank you for taking my call. The data released today shows fairly significant disparities in vaccination rates among white people and people of color. And I'd love to hear what your reaction was when you first saw those numbers. And also if you could talk a bit and just explain a bit how you explain those disparities.
Sure. This is Commissioner Malcolm. We weren't surprised in the sense, twofold really, that given the initial populations that were prioritized, healthcare workers and elders, initially those residing in long-term care, and then 65 and over in the community, that we know that both of those, all of those populations are disproportionately white. So in that sense, it was not surprising. But even among those populations, we see disparities in the percentages of population that are in various racial and ethnic groups among those who have been vaccinated so far. So it confirmed what I think community members have been saying, and what our own sense was from, for instance, seeing the makeup of those being vaccinated at the state sites. So while it wasn't surprising, it did sort of confirm where we have gaps, and will help to, and as we just laid out some of the strategies for you right now, how we will use that data to begin making more informed allocation decisions in terms of what a vaccine that's going to specific types of providers that are very focused on these communities.
And a quick follow-up, could you talk in a little bit more detail just how you plan to take this data and apply what you've learned to ensure equity, as the vaccine rollout, as the vaccine distribution continues to roll out in the next phases?
I think it's, again, it has to do with allocations to specific geographies and to specific providers who are serving the populations that are showing these gaps in access, and it also will inform our strategies to work with community-based organizations to make sure that we are both getting the vaccine to the right communities and through the right channels for accessibility, but also to be working to educate and encourage and support people in the communities to get the vaccine when it is available. So understanding the questions and concerns that specific communities might have, needing knowledge about the vaccine, needing encouragement that it is safe and effective and important. So working with trusted community organizations on those outreach strategies, and doing things like mobile vaccination clinics, and like providing supportive resources to help people actually get signed up, so that we can make that access, really tangibly real and not just theoretically available.
And Commissioner, this is Chris Ayers, I just wanted to jump on, and sorry, when Theo asked this question about doses, instead of unmuting, I hung up, but I just wanted to provide that information. Next week, we will be receiving 127,169 doses between Pfizer and Moderna. That's 67,860 Pfizer doses and 59,300 Moderna doses. And then I think, as you're aware, we had the Johnson & Johnson or Janssen vaccine that arrived sort of in between two allocations, and that was 45,200 doses that are in the process of being administered now and early next week. Thank you, and sorry about that.
And there are no any other questions at this time. You may continue.
All right. Well, as always, we invite any reporters with additional questions to reach out to our office this afternoon. Have a good day, and we'll be back with you again soon.
You've been listening to State Health Leaders with